Welcome to the Advantage Insights podcast. My name is Carol Wellaway, and I'm the founder and CEO of Advantage HCS, a healthcare consulting company. Our team is made up of passionate healthcare providers, all on a mission to transform healthcare. Through our Insights podcast, our team, as well as occasional special guests, will tackle today's biggest challenges within the healthcare industry. So, let's get started. Hi, everybody. Welcome to the Advantage Insights podcast. My name is Carol Wellaway, and I'm the founder and CEO of Advantage HCS, a healthcare consulting company. Our team is made up of passionate healthcare industry professionals, and together we are on a mission to transform healthcare. So today's topic will be about healthcare in rural America. So team, what do y'all think? What would you all say are some of the top health issues affecting rural communities today?
Retention of staff.
Yeah, staff retention's a big one. Everywhere it seems. Yes.
Access, yep, that's a good one too.
Access is a huge problem in the rural communities.
What are you seeing, Nikki, in your areas?
So I actually have the privilege of working both at a tertiary care center in North Houston and also in a rural ER. And our little small freestanding probably sees somewhere between 50 to 75 patients a day. And between us and another facility that's in the area, we are it for about 3 counties in Texas, which is a very large patient population. Some of these individuals have lost hospital systems that were around for 50, 100 years, and they just couldn't sustain. So these patients now have to drive upwards of 20, 50, 100 miles to get to the next, nearest hospital. And even there, a lot of those critical ancillary services like general surgery or cardiology, gastroenterology are not available. So they have to be transferred to the larger cities to get that tertiary care. And it's very difficult, pulls on the family, financial resources, time, things like that. So it's something that we really have to get a hold of, I think, in America.
It's huge. That's huge. Wow.
It makes a lot of sense. Yep.
Yeah. What about from maybe the surgical side of things? Susan, are there things that you're seeing and maybe different needs or a greater need in these populations?
I think the biggest need is just more. So currently the hospital that I work at, I would say it was previously a rural hospital. It's now the community hospital, but it's the only hospital system in the city. And, myself as a head and neck surgeon, the group that I'm a part of, there's only 3 of us to meet such a huge population, huge shortage. So wait times for surgery, the volume of surgeries that need to be performed. I mean, we have people waiting 3-4 months for surgery. So, and it's hard to get surgeons down here. That's a part of being a rural hospital. You've got the bigger cities, the metropolitan cities that everybody flocks to. It's hard to get surgeons to these places. So you've got such a great volume, and we are sort of at a bottleneck. We can only operate so many cases in a day. And that's a hard challenge. That's a hard challenge to overcome. That's the thing I would say is a big issue.
Yeah, that's a great point. All 3 of those points are very valid. And I just want to take this opportunity, from the data analytics standpoint, I work with these clinicians like this all the time, and these themes that just were pointed out is very common at every organization. A lot of times, like Dr. Jordan said, and Dr. Susan said, these issues are so large and so complex. You really can't just jump right in and fix it because you don't know where that problem is. There could be multiple areas of opportunities, but you don't have the resources, again, to attack all of them. So that's where I think this advantage that we have, really comes into play where, we work together and we partner together to look at these issues that you're bringing up. And then we look at all those buckets of opportunities and we use data to say, okay, it looks like we're doing fine here, here, and here. However, this bucket here, we're really short staffed on, techs. It really focuses in on where does the organization, where can these rural hospitals focus their money and resources to improve those areas? So I think every one of your points are very valid. The one thing I wanted to add to that was just the point of that value between analytics and the clinicians being able to solve that problem because it is so big, you just can't go after it. It's just too big of a mountain to tackle at once.
And I agree with that, actually, the value of analytics, because currently where I'm at, we're struggling. We're struggling to meet the needs, mainly because, and this is probably one of the biggest reasons why I was excited to join Advantage, is there is a disconnect. There's a disconnect between, what the clinicians and the providers are dealing with, what the leaders are seeing. We're seeing a lot of this, we're living the analytics, so to speak. We're living the issues, and we're seeing it from our standpoint. And we're saying, look, we can tell that these are the issues, and we know that the data will back us up. And there's this disconnect. And I think if we could come to the same agreement and look at the data and say, look, this is substantiating our experience. We need these many providers. We need to be actively working on this. That would move some of these pain points along. But there is that issue with sharing that common ground. And I think looking at the data would help support our experience.
You're absolutely right. And I can tell you, this is not commonly done across these healthcare organizations. You don't see that collaboration between clinicians and data analysts because they don't speak the same thing. They don't know each other's work. I think that's where I've kind of have found a lot of value in training up these analytics teams to take a step back. You don't have to become a clinician as a data analyst. You just have to be able to talk to them. Leverage the clinicians, let them help you understand the work processes and the workflows. And then you go pull the data. And that's where we're good at. That's where we can go pull the data and eliminate these perceptions of, last week we had a bad day with 15 patients had X. And I think that's where what you're saying is, that's where I'm seeing the biggest benefit is when these clinicians work together with the analysts and clinicians understand, hey, I can't do the data analytics and the reporting side, but I have somebody that can. And then the data analyst saying, I can't do this without the clinicians because I don't know the first thing about how this workflow is. Once that marriage and that union happens, that's when the walls come down, and that's where I've seen the biggest success. And I can say that with working with Dr. Wellaway and Dr. J, we've done this at other places. This isn't anything new. The unfortunate part is you just are not seeing that at these rural hospitals. They just haven't got there yet. I think is the biggest piece of it. So.
Well, I've always, enjoyed and look back really fondly on our time working together, Aaron, and how we were able to kind of come together and start maybe speaking the same language or sharing. And I mean, I learned so much from you as far as kind of what you're seeing. And it really did help me go back to the bedside, my leadership, and help be this kind of translator and help really move things forward when we would kind of just stall out, or people would have ideas, but then we didn't know how to move it forward. So I always appreciated your openness to talking with us and having these meetings and saying, okay, and I could show you what I was seeing, because maybe I couldn't say it, but I could show you. And then when you saw what I was having issues with, then you could interpret it and then get me the information I needed. And that way we could keep making momentum instead of people just being constantly frustrated and feeling like, there's no hope. This is how it's just always going to be. And that's not the case.
Yeah, I think that was
Always
beautifully
gonna
said.
be.
Yeah,
That's
that
the
was
worst. This is how it's
beautifully
always
said.
been done. This
Oh,
is
yeah.
how we do
that
things.
drives
And
me nuts.
I feel like
This is just
our
how we
team
do
is
it.
You got to break
definitely
those walls
about,
down. And I think again,
yeah.
all of us on this podcast, we can all agree one thing: patient care is top notch. That's the legacy we're trying to leave behind, is for the folks that we love and care about, we want them to go to the hospitals and have the best experiences, best outcomes they possibly can. And I agree with you, Dr. J. Looking back, years and years ago when we worked together is when my eyes opened up. Holy cow, the value in this partnership. Um, I'd never thought like that before. So being able to have such intelligent people, these clinicians that care about patient care as much as I did. And for me, I don't work at the bedside. So my thought always was, how am I really helping? And that's when my eyes shot open, was working with these clinicians, yourselves, and all you guys, is how I can do that. And that's how I can help, patients have those better experiences by giving you the data and the information you need to make sure the changes that you implement are in the best interest of the patients, and their health. So
Well, I think that this is just so great that we're talking about this and from these different experiences, and that we're focused on rural people that live in rural communities. It
absolutely,
always
yeah,
bothers me when, if you're the people who get the best access to things have to be near a major academic center. And everybody doesn't want to live in a big city or in a
yeah,
suburb. Some people really do better, that it's just where they're comfortable is being out in rural areas, but that shouldn't mean that they get less than what other people get. And I think, some of these communities and areas that I see where we have to be creative, or how do we increase that access when we've got staffing issues and other concerns, is, using telehealth, doing a lot with our mental health and making sure that folks that are in these communities still have access to quality care, and so that they don't feel like there's these two systems in our country, depending on what your zip code is.
I think it's
I think
very,
that's
very well said.
I think
feel
that's going to
like
be
we've
one of
talked
our
a
big
lot.
things
Oh, go
that we
ahead,
have to
Nikki.
try and figure out how do we entice, or not entice, but how do we encourage people to leave, or not leave, but integrate those large tertiary centers in those big cities and create a partnership with our rural communities. Because like for me, I live an hour away from the freestanding that I staff. And how do I, that's one of my big problems now, is how do I get physicians to buy in and want to help this community? What's the answer? I think that it is going to require a lot of work, not only on the analytics side, but on the physician side, but also on the hospital administration side, to figure out how we can work as a team to close that gap. Because the gap is getting larger and larger and larger as medicine matures, and it shouldn't be that way. So I think that that's going to be something that we really have to focus on in the next, 20, 50 years, to try and figure out how do we close that gap to
Yep.
better increase their access. Those patients who live an hour, hour and a half out from the city, how do we make sure they have access to gastroenterology or
Yep.
general surgery or cardiology?
I almost put it in perspective like this, right? You have the New England Patriots, who wins a ton of Super Bowls, has a huge cap. They can buy whatever they want, right? So these large hospitals, that's how I look at it. They can get what they want at any point in time. These rural hospitals are more like these fantastic football teams have great players, but they don't have the budget to go buy everything and anything. So that's where you have to work smarter, right? That's where you have to, um, almost be way more efficient. And looking at the data analytics again to help you provide, yeah, maybe we don't have enough staffing, but look, we're staffing on the bell-shaped curve. We're understaffed at our peak hours, and we have some people working in the afternoons that probably really don't need to be there. So I think it's looking at it through a different lens, understanding like, hey, we're never going to have that budget of whatever for these big hospitals have. We're never going to mirror that. But here's what we do have. And that's where I think, again, I keep going back to our skills and our experiences and knowledge in this area. But looking back at, here's what we have. We know we got this bucket. What's the best way to utilize that? And I think that's key for these rural hospitals. Is it's critical for them to have a very good plan in place on how they're going to budget and how they're going to resource, because that's very critical to their success, right? Compared to, I hate to say it, but compared to a larger hospital, oops, probably didn't need that, but they get it anyways, right? So that's kind of the way I'm looking at it, is through that lens of, it is very critical for these rural hospitals to have a good plan in place, focus the resources in the right areas, ultimately to help the hospital succeed. So
Well,
And,
poor planning leads to poor outcomes. We know this.
which is very true.
yes.
We live in a social age. We live in an age where we have never been more connected. Going to Dr. Nicole's example, in the hospital that I'm currently at, again, with the bottleneck of only 3 head and neck surgeons, very complicated surgeries that require bigger teams. I can't do, my partners can't do. But one of the things that we've at least done, sort of speaking to being resourceful, building, expanding our referral base, and actually having a relationship with larger tertiary care centers, is we have a good relationship with a few larger centers, in Phoenix and in Tucson. I mean, cell phone basis. So it helps me when I have a patient that, this is beyond the capabilities, the instrumentation we have here, but I have Dr. So-and-so on the phone. He's a good friend. He's in at University of Tucson. We have a very collegiate relationship. I'm going to refer you there, and I'm going to give him a call on his cell phone. He works, and this is actually true. I'm speaking of a real physician. The minute I call him, he works to get my patients in within a week. And so that's a relationship that we have cultivated as a group. So myself and my partners, we know them, we know their department. They invited us, in fact, to some of their didactics, to some of their conferences. And we really work to cultivate that so that we have that additional arm of treatment in our armamentarium. So even though we aren't in our small community hospital, we can still expand our ability to treat. And to the point Nicole made, and to a lot of these other rural hospitals, it is that kind of resourcefulness in this connected age that we can help them cultivate.
That's a really
I
good
feel like we've talked a
point,
lot
yeah.
about the data, the importance of that, and technology, even something as simple as a cell phone, and using that to connect patients to the resources that they need, which is huge. I think one of the concerns about these communities is they don't always have the latest and the greatest and the newest
Right.
when it comes to tech and resources in general. I think it's great that the people who live in these communities have advocated for themselves, their families, those who work in these communities, as I know all of us have at one point or another. That it's really hard. It's hard to be a patient there, and it's hard to be a clinician there too. And so all of this kind of outpouring of we need to do something different has led to some changes, both in the private sector and the government itself, looking at how can we provide more for these communities. Now, that being said, in order to reap the benefits of some of these resources, you do have to have some things in place. Like you kind of have to have those efficient processes, protocols, the data to make that happen. And I think that's one thing about this team is that there's so many people with such a huge range of knowledge, expertise, innovation. To your point, Dr. Susan, just hey, having a link between you and another colleague that has maybe the resources that your patient needs is huge. I know that's work that I've done in some organizations too, as we talk about staffing and how do you create more of a pipeline so that, although the world is changing and lots of things are happening, especially in healthcare, that that you're going to be able to bring in that next batch of nurses, techs, physicians, food staff who are going to be able to help provide for those patients over the longer term. So I think these are things again that we obviously see every day, but I believe our benefit is bringing all of these folks together to think through things and look at them in different areas and talk about how to make things different. So I think that's huge. We've talked some about the different issues in different communities. What do y'all think as far as the gap analysis? Like, what does that look like if I'm a rural community and I'm worried about us having to shut down the doors, close the doors and shut down, putting all of those patients at risk? Like, how do you start trying to figure out how to get out of that situation?
I think that requires a lot of maturity, not just on the part of hospital administration, but also for the physicians, that we have to sit down and we can no longer say, well, this is the way that I've always done it, because that mindset is how we got to where we are. It's a time to have an open table discussion where Aaron brings his computer and all his fancy numbers that I cannot add up. It is a time where Dr. Carol and Dr. Susan, Dr. J, we're going to sit down and say, okay, well, when I look at my department, these are the things that I'm lacking. These are the things that I'm doing well. Well, I have an excess of this. Can we shift this here? But it's a time when you have to have, in the words of my grandmother, it's time to put your big boy and big girl pants on and really have that discussion about how can we make this successful? Because staying where you are prevents you from moving forward, and not being able to move forward prevents your community from being able to do the same. So it requires us to be a lot more open-minded than I think that we've been in the past on both sides of the table. Well, on all three sides of the table, because we have to learn how to work as a true team. You know, before you talk about medicine in the 1800s, there was no hospital system. We didn't answer to, a C-suite. And then you fast forward to, the 50s and 60s. Well, docs are still doing what they wanted to do, but administration was in charge of making sure that the budget was okay. And now you fast forward now, and there's such a disconnect, like, Dr. Susan was talking about before, that we're now operating in 4 completely different zones. The patients have what they expect. The physicians have what they expect. Hospital administration have what they expect. And analytics have what they expect. And none of the 4 are communicating well. And that's why that disconnect is just never coming together. And so I think that is definitely where Advantage has the advantage, because all of us have worked in all of those sectors, and we talk to each other on a regular basis. I can't tell you how many times I've called Carol and been like, let me tell you what these fools are doing, because this doesn't make any sense. And then she says, well, Nikki, well, think about this. And I'm like, what? That's a thing? Okay, let me go back and think. You know what I mean? And then and the reverse is true. And so I think it requires just that level of openness and understanding. That's another thing. We've got to get that understanding that there's a way to fix this, and to make it a well-oiled machine so that everyone benefits in the positive and no one feels left behind.
Yeah, and
So
I would
important. Ask those questions, seek
Yeah.
help.
Well, I was going to say too, I think it's important. I've been in many of these executive boardrooms, and I've watched the C-suite sit there. I've seen clinicians sitting at that table, and then I've seen the frontline nursing staff managers sitting there. And then I watch the room as a data analyst, and I watch these conversations happen. And with my experience and background also in business, I can see the eyes glaze over when the data analysts present their numbers. No one knows what they're talking about. Clinicians start talking about what's wrong with them. And the clinicians, I'm a data analyst going, I don't know what you're talking about. C-suite's already like gone. Then the C-suite's like, okay, then what do we do? So I think what I've noticed the biggest barrier is, like you said, I think accountability is number one. You got to know, hey, time is up. It's time to get real. Second is, okay, now that we got all the C-suite, the clinicians, everybody on board, it's time to make a change. Now you start doing that change management piece. And we got to sit down as a team, and we have to have a neutral discussion. That means I come with my numbers, but I explain it in actual words that you can understand. I've seen this happen so many times, it's tragic. They come in, they throw up a PowerPoint. It has some graphs, has some lines on it with some numbers. And they're like, I don't know why they didn't understand it. Well, because you didn't explain it. You just showed some numbers and you didn't give any, the storytelling was just atrocious. So I'm with you. I think those 2 things are key: accountability, change management ready, sit down at the table. That conversation needs to be had that is digestible for the C-suite at the highest level, which they interpret things their own way. The clinicians, who are also they think differently. And so you have to be able to articulate to them clearly. And then, I think that's what I see missed a lot, like 90% of the time, is the communication, the vision. When you leave that room after that discussion, there's no next steps. There's no actionable movement, because no one knows what anybody was just talking about. But great points. I agree with you 100%.
And one of the things I would add, from the marketing perspective, because I like to think about marketing a lot. One of the things I often talk about is understanding your consumer base, because many times, especially with big hospital systems or any hospital system, the obvious consumer base seems to be the patient, which is for sure, that's a important consumer. But I like to think of it as you have other consumers in your hospital, your clinicians, your provider. They are a form of consumer base. They're part of the product, yes, but they're also consumers of the product in many instances, and then your staff as well. And so when you really think of, okay, this consumer and that consumer and this other consumer, then you have to do the work to understand your consumer. So starting with the patient as a consumer, what are their perceptions of the hospitals? What are the pain points that they are having in access, or even just trust? Do they trust the hospital system? I use that as an example because I've worked at a lot of apparently community and rural hospitals. And the first one that I worked at, there was a convention in the community, and I will not say the name of the hospital, but they said, if you're going to dun 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 dun, you're probably dying. And the name rhymed with the rest of the saying, but it was well known in the community. And when I started working there, I said, what is their perception of this hospital? If they think they're going to come here and die, well, then you're going to have patients who aren't going to come here, who are willing to drive an hour into the city or 2 or 3 hours because they don't want to die. So we really have to do the work to understand who are all the consumers, what are their perceptions, what are their pain points, and try to make a very clear plan for each of them, and understand that it's not just the patient, it is your providers. They have a very unique experience as clinicians, and there are pain points that come with that, but as also potential patients, your staff as well. So when you really think of it and you do the work with that understanding, then you really can peel through the layers of where are we going wrong here? Is it a perception issue? Is it a trust issue? Is it an access issue? Is it a cost issue? So that's something that I think is very important to understand.
Yeah, and I think it all rolls back up to, right? It all rolls back up to the C-suite executives, presidents understanding this issue and willing to make that change, and accountability for the change. I think it's very important not only to let's just make a change for change's sake, but let's make the right change and let's monitor that and see if we can sustain it. Because here's the other piece of this I've seen with my data analytics and performance improvement background. We'll change things all day long, but then in a month, guess what? It's right back to where it was because we don't sustain it. So we have to do the monitoring piece. And I know I harp on this a lot. Dr. Wellaway and Jordan's going to laugh at me, but standardization, documentation. Once we get that implemented and we see it's working, we need to document that so we can come back and we can monitor that and sustain it.
I know one thing I always ask is, what does success look like? And it's really important to understand that before you start trying to make changes. Like, getting to where we are is not good enough. That in and of itself is a step, because for some places, you're not able to get all of those key stakeholders that Dr. Susan talked about, on the same page that change is even necessary. But once you've done that and we say, okay, we need to change, we need to improve. What is improvement? How fast should it happen? How fast should we expect it to happen? What is the dip that we intend and expect to see before we make it to that peak? And how are we going to deal with that? How are we going to bring people along? How are we going to make sure that we're on target? And I think when people want to make changes, which is huge because not everybody does, then it's also important to understand what change management, I know, Erin, you mentioned too, what that looks and feels like, and to support the team along the way, because it is bumpy and nothing happens as fast as we would like. And I know we've all been a part of that many times over, and 100% never ever has it happened as fast as I would like. But it can happen. I also think
people have to make success. I always say, I'm a chunky girl, so ain't no way I'm about to run the Houston Marathon tomorrow, right? But my success is, first, I'm gonna run to the end of the block and back. Did I pass out? No, that's a win, right? And then I'm gonna run around the block maybe
I love
one and
that
a half
though.
times. I'm not gonna say twice, but we need to make it measurable so that
Yes,
like
yeah.
those baby steps, they count for something. Like we're not gonna get to the top of Mount Everest. Well, I'm not going to Mount Everest. You get what I'm saying? I'm not gonna run the marathon tomorrow. I got to take one little bitty step at a time, and
Well,
those steps count. We have to give ourselves credit for the
yes,
wins that we do make, but know that small win is not the end of the journey. We got to keep going and keep winning, so that when we do get to a point where we've reached that and we're like, oh my God, look how far we've come. It's not like, oh God, we didn't. It's another thing that we didn't get done yet. It's just like take the wins for when you get them, so that those small steps make you feel, or not make you feel, you understand that you're making a move in the positive direction, and then making that transition doable in smaller steps. If your staffing is down, like let's say we're down 10 providers on the day shift, well, we know we're not going to hire 10 in the next 6 months, and not be able to retain that. So let's say, okay, let's plan for one new hire every 3 months, make sure that we train well and we retain over the next year. That's measurable. We can do that, and then we can move on to making sure that we fully staffed on day shift, night shift, mid shift, swing shift, and all those other things. So I think that that's the other part, like give ourselves the grace and the kudos for doing the little things that lead to making the big things happen.
And I'll say this too. I love what you said about let's get some short-term metrics to show that we're succeeding. Because the other thing that I see fail a lot on the data analytics side and the PI side, right, is they'll set unrealistic goals and targets. Like in 3 months, we want this resolved. I get that a lot in my work. Like executives, like I want this fixed yesterday. Well, guess what? It didn't just happen yesterday. This has been happening over a period of time, and it's going to take just as long to fix it, right? I think for me, that's the hardest thing to sell to executives is like, this isn't going to be an immediate fix. You're going to have to give it some time. And one of the things I try to talk executives off of is if you don't have a baseline, then let's not set a target. Like, let's not set a threshold because we don't even know where we're at. We need to know current state to know what we want future state to look like. So I love everything you just said. I agree with you 110%. Love, love, love taking those small wins because the biggest issues is you're going to burn out everybody busting their hump trying to fix this if all they're hearing is we're not there yet, we're not there yet, we're not there yet. But if you can say, hey, we met our first goal and we got 10 more steps to go, but hey, we just hit the last 2, I think that's great. So great call out. Good stuff.
Yeah.
So I know some of us here are involved in teaching, and whether that's students or residents, we've seen that. I know I've worked in places, both in community hospitals and large institutions, where academics is a huge part of providing care in those organizations. What do you all think about that, specifically looking at our rural communities and how maybe we could leverage the academics in these communities?
I think we need to go back to exposure. I'm gonna make this, it doesn't have anything to do with rural medicine, but I was talking to one of my residents the other day and they were asking me about the coroner coming to check on a patient that had expired. And I made a comment about the autopsy and they kind of looked at me cross-eyed and I was like, have you never seen an autopsy before? And they were like, no, why would I? And I was like, I'm sorry, that used to be a requirement in medical school. Like, how did you? I remember autopsy day. Like, I that is ingrained in my memory. When I am 95 and demented, I will remember that day. And I said, how is it that you got through med school and you never got to see what that looked like? Right. And they just kind of looked at me. And the same thing goes for emergency medicine. I missed it for 75% of my med school career. And it wasn't until I was kind of forced into it that I was like, oh my God, I want to do this. I don't want to do what I was doing before, but it was because it wasn't presented to me. And so I think that we have to go back and start presenting rural medicine to people as an option, because right now all you see is the derm and the surgeons and the trauma, and nobody thinks about that rural community. It can be a rewarding life. Lots of someones would want to do it if they knew what it looked like. But we have to start giving them the opportunity to see what it looks like. And we also have to open up to being willing to do it. I went from not teaching to not teaching again. And then I got thrown into teaching again. And I was like, how did I get here? But then I remembered, like, somebody has to do it, right? Because somebody had to teach me at a point. And I think that we have to start making it more accessible. We have to open ourselves up to the education to let those who are coming behind us know what it's like to practice in these places so that they know how to keep the torch going. We're like the Olympics over here. Like, I got to pass the flame to somebody. I'm getting too old for this. So, the ones who are first and second year med students, they need to know what it looks like. So when they get out, they can say, well, do I want to be a surgeon in the big city? Or do I want to live on 20 acres out in Polk County, Texas, and do surgery at, hospital X? But they don't know if they never see it. We got to let them see it.
I got a question for you guys, and I really don't know the answer to this, but I'm really curious to get your thoughts. One of the big things I teach with the data analytics teams is always trying to use that analyst to their fullest capabilities, to their skill sets, right? I wouldn't put someone that can't talk to people with a customer-facing job. So do you feel like in the rural hospitals that we're optimizing like in that area, or do you think there's room for improvement there too? Like if we got somebody in, like you just mentioned, they're really good at documentation and maybe like they enjoy showing other people how to do things. Do you think we're missing opportunities there of identifying these leaders and grooming them?
Big time. Because if you'd asked me when we were in med school, and Carol and Susan can probably attest to this, I remember being there and being like, there's no way on God's green earth I'm going to practice emergency medicine. Okay. Also, back then,
OB, you're all OB.
I was. You couldn't have told me that I would be a medical director in rural Texas. Nothing about me. I'm from the south side of Houston. Nothing about me said that that's where I would have wound up. But I'm also married to somebody who is a rancher at heart. This boy break horses on a regular basis. And so ultimately, that's our goal, is to move to a rural community. And so I think that people I've got residents from Philadelphia, from New York, from Chicago, who are now like, I'm like, are you going to go home when you're done? They're like, no, I'm going to go up outside of Dallas. I found this really kind of like sleepy town. I'm going to go work out there. And I'm like, really?
See, I think that's so interesting to me, only because I was just talking to, I do a lot of mentorships with young analysts, and I kind of coach them on what to expect. Because I feel like that's one thing I missed out on when I was going through college. I had no clue what I wanted to do. I knew I was a data geek. I knew I loved numbers. I just didn't know what was I going to do with it. And I made a lot of wrong turns, went down a long career paths that wasn't really my passion. And I ended up now where I'm in a place that I love. So now I try to give that back to these younger developers. And I look at this as an opportunity. The reason I bring this up is I look at it as they could do the same thing in healthcare, right? You could get your hands on these, medical folks early and start trying to figure out like, hey, what do you like to do? What's your passion? What drives you? And it may not be the same today in 10 years, what drives you, but knowing that, I feel like gives you a very good advantage to your blueprint of how you're going to roll out. And I think to your point, you're going to find a lot of people that say, I just love rural life. Me personally, I'm one of those. I love the, rural communities. That's my jazz. That's where I'm at. But a lot of people don't realize that they can work in rural and have a life that is just way different than working at an academic setting, right? And I think that's important because without that knowledge early on, you'll find yourself working in an academic hospital saying, how did I get here? I hate this. And guess what? Probably going to burn out. And hopefully don't leave healthcare because we need them. But I mean, these are all things where I feel like we could do such a better job of, let's get to know, Dr. J, Nicole, Susan, and what do you love? What's your passion? What's your drive? Let's get you to where you fit best in healthcare, rural hospitals, and let's get you in there and let's let you knock it out of the park. Because that's what we're all trying to do, right? But
I was going to add to this, but I watched Dr. Jordan shake her head emphatically, and I kept thinking, what was she going to say? I'm curious, because she was like, I was thinking of sharing my point, but I was like, no, I want to know what she was going to say.
Oh, okay. Well, a couple of things that I was just thinking about. There's always that saying of you can't be what you can't see.
Yeah.
And,
Yes.
when we have folks that are not able to see it, they weren't exposed to it, that's a missed opportunity. And then the other thing I was thinking of is that for people that have found their area, their location that they're passionate about. And when we started, I was talking about how we have people who don't stay. But if we can find the people who found an area that they are happy with, the work environment, and they become mentors, when we're talking about staff retention, if you have those people that are passionate and you give them time and space to mentor the next generation, that can help fight burnout because it actually gives them an outlet. And instead of just kind of the grind, you can be inspired. It's a two-way street. Mentorship is supposed to be bi-directional. And so you get some, fresh perspective. You get re-energized when you see these people coming, and then they get to see it can be done, that this isn't when everybody else is telling me, you don't want to be out in the country, you don't like horses, you don't. But if that's where you are, but you have to see it, and seeing somebody ahead of you that's done it gives you that confidence when nobody else, they're scared and it's a reflection on them and they're not comfortable with it. So they're trying to make you be somewhere where they're more comfortable with you being. And so I just see that this mentorship and this partnership as a way to help grow that environment and change what people are often hearing, because you've got to be that counter voice with whatever they're hearing at their institution or other places that say rural is not where you want to be.
Mm-hmm. Yeah. I love that point. You can't be what you can't see. I'm gonna take that and claim
I'm stealing that.
She's full of them. She is full of them.
Yeah, I love it. That's
but it's
yeah,
I mean, perfect. To your point, it's important to provide that pathway, to cultivate that talent, show the options. The hospital that I work at currently, they've actually done that in a few instances through some training programs. Both, we have a few residency programs. I mean, we're by no means as robust as a big training center, but we do have some, again, to bring that talent here. But they've even cultivated programs within the hospital for different sort of staff opportunities. And that has given these people who've grown up in this community, they're not leaving this community, an option to see something else, to be a part of something else, and to, enter into the career of healthcare without having to move to Phoenix. So that's a good opportunity. I like that you said that.
Yep.
And with that, I think we'll take a quick break. Nikki, and then one thing that we haven't gotten to yet, I think Dr. Day alluded to, is the importance of wellness and being kind of having more of a work-life integration now, not so much balance, but integration. Nikki, I know you have a swim meet to get to.
We're doing a swim-a-thon.
Yay! Good luck.
She's preparing for that half marathon, I think.
Yeah. So a triathlete is what you're trying to be.
Triathlete.
The next podcast.
It's coming.
I'm in the back with my pom-poms.
Yeah, there you go.
That's it.
Really.
That's it. It was great. I will see you guys next time. Thank you.
It was a pleasure. Thank you.
Thanks.
So, but I get really concerned about when we have issues and we have it and but poor planning leads to poor outcomes. And so when we just start doing things and we have limited resources, limited number of people, and time is our most precious resource. Where we spend it, who we spend it with, like that is crucial. And so when we aren't doing needs assessments, we just start doing things, we're just, doing it. And then we wonder why it didn't work. But we never went back and talked to the people that were directly affected, our patients, like what do they need? We didn't talk to nursing. Like, was this really a problem? Like what was going on? And so then we start off with a bad design. We're spending energy on stuff that maybe didn't need to be fixed, or we're not fixing it the right way. And when that happens multiple times in a system, that's where the cynicism, skepticism, burnout, and people are like, I'm not signing up for another project with y'all because it's already setting up a negative or a poor outcome mindset. And so when you're starting with that kind of a mindset, it breeds into an organization where they think that this is all we're going to do. We can never get better. This is how it's always been done. And so you lose that opportunity to improve.
I'm curious to see what you guys think about this too, because again, I'm going to go back to my performance improvement days and that aspect and say a lot of these projects you're talking about, these where they fail, is based off these continual improvement teams, process improvement teams. They establish these Kaizen events or rapid improvement events, and generally they're I hate to say it, but they're like something that got kicked off because of either a perception or hey, I think this happened. We need, or maybe the executives got an email like, hey, you're looking poor on readmissions. So they just knee-jerk reaction. They set up a team to combat this issue. The problem and the issue that I have with that is, and I'm curious to get your feedback as well from the clinician standpoint, but what I see is there's not a lot of pre-work done. It jumped right into the problem solving without any, like what you just mentioned, without any pre-work. Did we speak to the right stakeholders? Are the right stakeholders involved? I've seen that a lot. The wrong people are in the room for the discussions. And then they go as far to start making an action plan on, okay, Dr. J, I want you to do this. Dr. Wellaway, go do this. And then Dr. Susan, I want you to go do this. But do we really know what the impact's going to be? Or are we just assigning work to be done because that's how we've always done it, right? We got the issue in front of us. Let's start assigning work to people. But we don't even know that what we're doing is really going to have the impact we expect. So my philosophy has always been, since working, back in rural hospitals years ago, I changed my philosophy from like trying to implement a change quickly to really let's understand the problem. Let's take the time up front to all be on the same page that yes, this problem exists. We need to fix it. We have the right people in the room for the conversation, and let's work as a team to decide what those next actions are. I've seen the most success from that, but I'm curious to get your point of views if you've seen the same thing.
And I'm going to go out on a limb and I'm going to say, and I've seen this. This is why I'm going to say this, is I have seen in organizations, big and small, this idea where, exactly as you said, Aaron, this number looks terrible. We got to do something about it. So the people that I hire to do things start doing something. And that something may not be addressing the right problem. It may actually not be a problem. The people are working on the wrong things. The process developed is wrong. Maybe it starts affecting poorly in a different area. I mean, there are all kinds of things that happen when you don't clearly identify the problem. Yeah. I have seen in some organizations where a problem is identified, and sometimes appropriately so, and there's work to be done to fix it, but that work is not necessarily in earnest. So sometimes it's good enough just to look like you're trying to solve a problem. And when that happens, well, one, the problem doesn't usually get solved or even identified. And to your point, Dr. J, then we have people running around doing things, then the cynics and the snarls of, oh, here we go again. We must have a new leader.
Flavor of the month.
Another email. Here's the flavor of the month. Yep. Oh, don't worry about it. Nothing's going to change. Just sit through it. Nothing to see here. Yep. Whereas I think because we do this work and we do it at different levels, at the bedside and in the boardroom, we are privy to a lot of different discussions that individually, not a lot of people hear both. And so being able to bridge that gap and say, no, this actually is a problem and it matters. And although we might get by not actually fixing it, at the end of the day, there are people's lives at stake for this. And so it is important to understand the problem and get the right solution to fix it. And I think that's something, I mean, this group of folks, I could not be more proud of because we all have this same mindset. We all think the same. It's not just about fixing the numbers. There's so many projects that I have started based on, hey, we need to fix these numbers. And my response is, I think the numbers will improve but I'm not going to focus on that. And nobody wants to hear that. And 9 times out of 10, the numbers do improve. But the way you go about doing it can make the difference as to, one, whether there's improvement, two, whether it's sustained, to your point, Aaron. You may have a little bit of improvement. We did this, we're going to change this process. And then a week later, everyone's doing what they were doing.
Well, and I want to say this
That's
too.
really, really important.
And I want to just throw this out there too. You're getting told, right, that they want to see the numbers improve. But we all know that the first thing that happens when we implement change is our numbers do what? They look worse.
Look worse.
You're
Yes.
right. Yeah. So you
Everybody
have to
doesn't realize that.
No, they don't. And that's where, like, it's key that people understand with what they're seeing and what's happening. Don't pull the plug if you have a bad month. That's my biggest pet peeve is I see these leaders, they panic at, a daily number or a weekly number. And I'm like, hold on, you need a larger scale before you make that decision. There's a lot of variables, external variables that could cause these things. So again, I love the point. Don't focus on the numbers, right? Those will change. I agree with you 100%. If you are going to look at the numbers, please, please, please make sure you have someone that can explain those numbers and help ease the minds of the leaders saying, guys, we did look worse this month, but I do want to show you this other area we improved. So little by little, guess what? Next month, we're going to see this go up, and you will as you continue to improve. And then you also there's just a lot there to unpack from a data perspective, being able to articulate and not cause panic. So Dr. Wellaway, I love that point. Agree with you 100%. Don't focus on the numbers, focus on the improvement, and let the people that know the numbers explain whether it's working or not.
It's really trusting the process,
Yes,
like it's
yes.
letting the process
Yep,
play
yep.
out. I think setting, again, those SMART goals, realistic expectations right from the beginning so that it's clear and upfront. And for people who are, there's a lot of anxiety in healthcare. And so attending to the emotions, some of the stuff people, they want to do a good job. We all went into this because we wanted to help people. But, and we're so used to like this, getting things the next day, overnight shipping. But some of this stuff is going to take time in helping guide people and being that guide on the side as they're making these things. And that it may get uncomfortable, but we've all been in these health systems. We've done this with other programs and organizations. We know that if they stick with it, they stop trying to tweak things as we go, but let the process, trust the process, leverage your experts who are going to guide you through it, because then that's going to help build those wins, build that confidence, quiet those naysayers and the skeptics who thought that this was never going to change at your institution.
Yeah,
and I want to emphasize a point that we've already touched on, but for those who are listening to this podcast or watching, the clinicians oftentimes, when these projects are proposed, say the same thing. I've been in multiple institutions, you guys have as well. There they go doing what they do. When you hear that and variations of that, you know that you do not have the buy-in of a team. We are a team. We practice medicine in a team. That's what we're taught. And it is very much a team effort to change the culture of a hospital system, to implement some of these sweeping changes. You cannot do this alone. You cannot do this from the top and expect that those who are carrying out the work will do it diligently, thoroughly, and as you desire. If their first inclination is, there they go, doing what they do, it's us versus them. And, some of the things that we talked about earlier, all of these things that bringing these clinicians and providers and staff on board, it instills this idea of trust. One of the things that we know is an issue if we don't do that, aside from the cynicism, aside from, the complacency, we'll brush it off, we'll ignore them, is turnover. When your staff and your providers do not trust you as an institution and have not bought into you, they're not invested in you. And they're more likely to go down the road or to the next opportunity where they feel better supported, are getting paid more in many instances, and they feel like they can grow. So it is so worthwhile to cultivate as hard as it may be, it is worthwhile to cultivate that environment where your clinicians and your staff and the key stakeholders feel like their say is important, feel like you are invested in improving things with them on board. If not,
Yep.
you run the risk of losing them.
Yeah, and I will tell you, to piggyback off that, I've been in many rooms where those comments have been made, even more negative. But I look at that as one of the things. I love challenges like that. The first thing I do is I try to understand why the negative, and you know what? It generally usually spawns back to an experience they had on a project. They don't feel like they're listened to. They've been doing this forever, but no one wants to hear what they got to say. But I think that's again where, you said it earlier, and I think that's our difference, is that we function not as a one person, but as a unit. Advantage HCS is a family, is a team. We do everything together. The same thing is true at these rural hospitals. I would think that if I had a physician who was like, forget this, you guys are going up, you're battling up this hill for, I'm not helping. I'm going to take the time to understand, like, why not? What do you see that we don't see? What have you been through that we don't know about? You're probably going to discover something that's going to help you mitigate a risk, or mitigate risk or waste, I'm sorry, of going down a road that you don't need to go because you've already done that. You could learn from this person. And also, to your point, it's going to take time because you don't change someone on that sliding scale from completely disinterested to like, I'm all in. That's not going to happen in one conversation. It happens through, you said it, trust. They need to see that you're going to do what you said you're going to do. They need to know that you're going to hold people accountable. That's a big one. And then they also want to see, are you going to listen to me? Are you going to value my input? Am I really a part of this team? And guess what? They know if they're not. I've seen that.
Yes.
That'll break your team down quicker than anything. So I think active listening is one of those things I call out on everybody. It takes just as much to talk and tell people what to do. And it's even harder to sit back and just turn your mouth off and just listen to what's going on. And then you can add more valuable input. So
For
great
sure.
point.
That's why we have 2 ears and 1 mouth. that I've had more than once with senior leaders and decision makers about the input of the team, usually physicians, but to your point, Erin, not just physicians, any stakeholder that's on the team. And I know a lot of times with physicians, our input can sound like complaining at best sometimes. And what I've had to tell people is, I know it sounds like whining or complaining, but if you get past that and you listen to the words, you will hear answers and solutions to some of the problems that you have. You may hear answers to problems that you don't even know you have. And so I think one thing that I've done in my career, and I'm really excited to have now a team of folks helping with this too, is to do that translating. So one, to help our leaders, our decision makers, our board members understand what the issues are from the side of the clinicians or the folks at the bedside. I'm huge in all that I say. And people know, oh, Dr. Bowlway, can you work on this and that? And it's like, I can, but I'm not going to give you the answer. The answer always comes from the bedside, because those are the people that are in the trenches. They see the problems every day. They have to live through it. They've already came up with 13 workarounds on how they're getting around this problem. And oftentimes those are the people saying, if we just did this, we wouldn't even have these issues, but nobody listens, nobody cares. The woe is me. And a lot of people who say those things have reasons, whether, usually the organization isn't coming out saying, we don't care what you think, but that is what they're feeling. And because of that, they're acting in a way that sometimes is not always respectful, not always beneficial for the team. And probably the most tragic piece of that is they have information that could benefit the team and benefit the communities in these cases too. So listen to your people up the ground. At the same time, as a physician leader, I spend a lot of time in educating my colleagues on how to say things in a way that people can hear, that doesn't sound like whining or complaining or absolutely not disrespect, and kind of playing both sides and helping both come to the middle. And I think that's one thing, again, with this team of folks, and again, we've got clinicians, we've got people in data, we've got people in finance and insurance as well, who see all sides. As a group, we can see all sides of these situations, and really work toward bringing people to the middle to improve things for all of the stakeholders. So really excited about this conversation and obviously our future conversations as we really talk through how we can help transform healthcare.
I think that's really great too. The one thing I want to say about that is I heard it numerous times, but we're not providing a box solution. That's not what we do. Um, and I think that's very important to call out because I've been a part of many organizations who are like, "Hey, Hospital X is doing this. Let's do that here." That's not how it works. Everybody on this call knows that because we've experienced it. We have the knowledge and the brains that knows you need to know the business. So the hospital, you got to know the hospital. You got to know your staff. You need to know the patients that you see, and also understand that you're unique. Every hospital is unique. So, to Dr. Wellaway's point, with the experience we have on this team and all these skill sets that we have on this team, we are able to have that conversation with your hospital, identify that custom solution, and provide you with a path to achieve that. Whereas a lot of times, what you'll receive from other services, will be this is how so and so did it, or hey, here's a blueprint that's generic and might get you a little bit down the road. But what we offer is we're going to tell you exactly how your hospital should react, exactly what you should expect to see from the results that we're going to share with you, and then ultimately help you get set up to achieve that success from that custom solution. So I think that's very important. And I wanted to make sure that that was said, because again, I think that's what sets us apart, is that you are getting the optimal solution for you, not for anyone else, but for you.
One thing about change management, and it's always difficult. That's one thing. We just have done it enough times that we know the patterns and we know that you can push through it and have success. One of the benefits, although our rural communities are up against a lot, but one thing they do have going for them is that they're smaller. There are fewer people that you have to get these messages out to. Many times the people that work in these communities are dedicated to that patient population. They live there, they're invested. That's a huge part of getting people to do something different and gaining buy-in, is they kind of have to have some skin in the game. They have to care about something. And so that's one thing that I'm really excited that we're going to be able to bring to our colleagues in these areas. I do want to put out a little plug that we will be at the American Hospital Association Rural Healthcare Leadership Conference in Orlando, whoop, whoop, February 11th through the 14th. So you will be able to meet some of our Advantage team members there. We'll be at table 40. And we would love to help you and your organization improve healthcare. We're here to transform healthcare. So let us help you. And with that, I think we will close. Any other comments? Dr. Jordan, Dr. Susan, Aaron, anything we want to add for this session?
No, I think it's clear that we're all excited to help share our experience and knowledge. And I'm excited to hear and meet these individuals at the conference. I know I got some friends that are going to be there, so looking forward to seeing them, and seeing how we can help with our experience and knowledge transform healthcare. So very excited. Look forward to meeting you all.
The more challenging, the better.
Yeah, we're
Absolutely.
not afraid.
There's nothing that we can't do. We'll see.
That's a little bit